Good afternoon. I'm very honoured to be here, and I'd like to take the opportunity to thank the organising committee for giving me the opportunity to talk with you here today. And I'd also like, of course, to thank you all for making the effort for attending this workshop. We're quite grateful for that. I've just got too many things in my hand, so I'm going to put down some things. I'd also, before I do start my presentation, like to acknowledge Hiroka, who is going to interpret my presentation today. And I've assured Hiroka I will speak slowly and distinctly, which will probably be the first time in my life I've been able to achieve that. I work in Peter Mac, as Caitlin said, and the Peter MacCallum Cancer Centre is a standalone cancer centre in Australia. And we moved into our new premises 1 year ago, and this is the centre where I currently work. When we did move, we moved all our personnel. We got some new equipment, including some new radiotherapy equipment. But we also, importantly, which I think for cancer care and indeed for life in general and for nursing care, we did bring some of our old equipment that were part of our old building. I've put that up as a technical slide. I'm not going to give a technical presentation. I'm a clinician and I'm going to talk from a nursing perspective and give an overview on the role of radiotherapy in the care of lung cancer patients. And when I predominantly talk about lung cancer patients, but I will also, of course, make some reference to the role of radiotherapy in mesothelioma patients. So I'm going to briefly give you an overview. As I said, I will talk about when and why radiotherapy is used for patients for lung cancer, and talk about some of the issues that Mickey also mentioned, and it's nice to know that the issues are global, the challenges that we do face today, and some of the dilemmas we will have for tomorrow and for the future in the work still left undone. And importantly, I think we need to talk about the implications for nurses, allied health, and of course for patients in the advances that we make in our cancer treatments. So I'd like to share with you some data from our centre, and I'd like to acknowledge and thank my colleagues Marlies, Alexandra and Anne Officer for obtaining this for us. We've got a thoracic malignancy prospective database in Peter Mac. It's probably 5 to 6 years we've been collecting this data. And interestingly, in preparation for today, I just thought it'd be useful to know how many of our patients have received radiotherapy for lung cancer. So of a total of 1,801 patients, interestingly, there was over 2,500 courses of radiotherapy prescribed. And what was very interesting for me was over 70% of our patients had had some radiotherapy during the course of the treatment. Over a third of those were with curative or radical intent, and just over a third again were with palliative intent. And I must say I had thought that our numbers for palliative radiotherapy would have been higher. I do need to point out that of those numbers, of course, there'd be some patients who would have had originally had radical or curative radiotherapy, but as their disease progressed and caused some symptoms, they would also, of course, have received a course of palliative radiotherapy. So radiotherapy for lung cancer, we will hear a lot during this World Lung Cancer Conference about the important and exciting advances we've made in systemic treatments, and particularly with our newer agents, be it the targeted therapies or immunotherapies. But I think it's timely to remind ourselves that some of our older treatments are still very valid today for our lung cancer patients, and we should not deny them access to any treatment, be they old or new, which can improve their quality of life and make a difference to how they live their life. And I like the way Mickey put up in Japan, they talk about living and wellness in the same way that we do. So we give two types of radiotherapy, really. We give curative or radical intent radiotherapy for both non-small cell lung cancer patients and small cell lung cancer patients. And of course, we give radiotherapy in the palliative setting to both groups. So for locally advanced lung cancer, and by that I mean somebody who has got stage 3B non-small cell lung cancer that's unresectable, and we offer this group of patients radical chemoradiotherapy. So in other words, we give them a combination of chemoradiotherapy at the same time. When I talk about radiotherapy today, I'm talking predominantly about megavoltage therapy, but I do need to point out that, of course, most cancer centres, including ours, still do deliver some superficial radiotherapy, particularly for some subcutaneous metastases that may be causing pain or maybe prefungating, and also some deep radiotherapy. And we also use intraluminal brachytherapy in a palliative care setting, but I'm not going to highlight that today. Internationally, the doses of radical radiotherapy given vary from 54 to 66 Gray, and like the Japanese centre, standardly in our centre we give 60 Gray radiotherapy as a radical dose with different combinations of chemotherapy. The chemotherapy combinations most commonly used are cisplatin and etoposide, or carboplatin and one of the taxanes. I'm aware that other centres globally use different combinations of chemotherapy. And in Peter Mac, and I'd like to acknowledge David Ball for sharing this slide with me, but in Peter Mac we've also got some data on radiotherapy outcomes over time. So you can see in the 1980s our outcomes, like the rest of the world, were nothing to boast about. So they were 5%, but pleasingly by 2013 there's been a significant change with a 30% improvement in outcomes for patients with lung cancer. And that of course is due to a number of things, not least to the advances that we've had. Of course, in my life as a lung cancer nurse, nothing has changed the outcomes of patients with curative disease, I would say, as much as the advances in the PET scan as part of the staging and diagnosis, and I'm sure most of you would agree with that. I'd like to draw your attention when we're talking though about about radical radiotherapy and about studies to this study, which some of your centres may have participated in, called the Pacific study. We didn't. But this is a randomised control trial where there was one of the monoclonal antibodies, Duffy, I can't pronounce that very well, was versus placebo, was used as adjuvant treatment after radical chemoradiotherapy. And it has actually shown significant improvements for the outcomes of this group of patients. And importantly, its progression-free survival is significantly longer. And you can see the difference in the response rates. Those who received the monoclonal antibody had 28.4%, as opposed to those who received placebo as 16%. And importantly and pleasingly, the mediation duration of the response rate was longer. So this was an interim analysis at 18 months. These sort of studies are very exciting for us as nurse clinicians, and of course as for patients and their families, because we talk about numbers and titles of studies. But this actually can change somebody's life. And Mima shared with us the story of her grandfather, and it's very pleasing for all of us who've had somebody who's had a diagnosis of lung cancer to see the changes that our colleagues have made and continue to make, and that we as nurses can contribute to in the future. So I've talked so far about radical radiotherapy for non-small cell lung cancer. I'd also like to talk briefly about the role of radiotherapy in small cell lung cancer. And as I said previously, we talk about it for curative intent as well as palliation. And for patients who've got limited stage small cell lung cancer, we use combinations of chemotherapy and radiotherapy. In our centre, for patients who are of a good performance centre, we use the Chirisi regime, which is hyperfractionation radiotherapy twice a day over 3 weeks with chemotherapy. We usually give our radiotherapy in cycle 2 or 3 because practically that's when we can aim to deliver it. And we also use prophylactic cranial irradiation for that group of patients. And for patients with small cell lung cancer who've got extensive disease, chemotherapy is the gold standard of treatment up front. Occasionally, we do give those group of patients some palliative radiotherapy to their chest as well, and we also offer them prophylactic cranial irradiation, which I assume is very similar to what many of your other centres do. So, of course, we talk radiotherapy as any cancer treatment causes toxicity or side effects. It's a local treatment, so the toxicity that patients experience is very much dependent on the area of their body that they've had the radiotherapy to. And I would say, with the exception of the systemic toxicity of fatigue, most patients with radiotherapy, and I think that as clinicians is probably a toxicity that we underestimate the impact it has on patients coming in for treatment and living their lives and afterwards. So other toxicities most commonly experienced by patients receiving radiotherapy to the chest would be a skin reaction, and also some esophagitis if the esophagus is in the radiotherapy field. And the scales that are most commonly used for grading of the toxicities are the RTOG or the CTCAE grading scales, which I have not put up there today. Other toxicities that in the era of immunotherapies and targeted therapies we're very respectful of, and I think we need to be, are those, of course, the toxicities, acute and late toxicities to the lung tissues, the lung parenchyma, and by that I mean pneumonitis or fibrosis later on, which is a significant toxicity that we manage. And I think that all of these toxicities, of course, draw on the strengths of a good multidisciplinary team. We work very commonly, even though the oncologists, the radiation oncologists and the medical oncologists prescribe the treatment for these group of patients, we draw on the experience and expertise of our respiratory physicians in helping us guide the management, particularly with steroids and particularly in the dosages that we need to use. So I'd just like to elaborate a little bit further on toxicity, because I think that is an area that nursing and allied health, I would challenge that we could possibly do some more research and be more involved in doing some studies. We talked yesterday at the Nursing and Allied Health Day about doing some studies internationally, which may seem like a pipe dream, but I think if we reach for the sky, we'll hit the ceiling in working together in some of these studies. And I think Kim Rowan's idea of doing international small nursing and allied health-led studies can make a difference to the lives of the people we look after. Now, when we talk about toxicity from any type of cancer treatment, we must often think of physical toxicity. In other words, the skin rashes, which we describe and we treat and we manage, which are very important, the esophagitis or the pneumonitis, and of course they are imperative for people to continue to live with their disease. But I think one area that we don't talk about, the toxicity of any type of cancer treatment, and I think our mental health colleagues would say that we neglect some of these areas. And we heard from a patient yesterday who came into our Nursing and Allied Health meeting and reminded us that she's been diagnosed 3.5 years and nobody on our healthcare team asked her how she is, how she's feeling or how she's doing. And that was astounding. But in 2017, as we take home lots of messages that we learn at this conference, I think as nurses and allied health, we need to take a stand and make sure that that woman's experience is not the norm. That we've got a duty of care to explore the toxicity of the emotional, psychological. And I don't think there's such a thing in the literature as social toxicity. But in my opinion and in my experience, that's what we're talking about. If people can't live their lives to go out to interact with their family, if they're too fatigued to collect their post, their whole social life is in disarray. And we've got the capacity and we've got to be able to there are a number of tools at our disposal to be able to assess patients. We talk about physical assessment, but their overall holistic, if you like to call it, or emotional and well-being assessment is imperative that we don't neglect. And we touched on financial toxicity yesterday in our meeting, but I'd like to draw the attention of a group in Australia who published in the Cancer Forum of July 2017. The Cancer Forum, for the non-Australians in the room, is a publication by the Cancer Council in Australia. And there's a number of very nice articles about the financial toxicity of cancer care. And they talked about 3 stages of that. Monetary, which is out-of-pocket expenses, but they also talked about the objective financial toxicity. In other words, the lengths that people have to go to, the remortgage houses, the borrow, they get into more debt to try and help them with get through their cancer care. And I think it's important when we're listening and getting excited, as we should do, about the advances we've made in systemic treatments, that this financial toxicity for patients and for their families and for the community we live in is only going to increase as we make advances in, which is great, in improving the outcomes of people with lung cancer. And they also talked about the subjective financial toxicity, and that had implications for the last point I made, and that is about the psychological impact of that financial toxicity on the lives of the people who we look after. So in the 4.5 minutes remaining, I'll just talk a little bit about palliative radiotherapy. Palliative radiotherapy for lung cancer patients is used, not surprisingly, to alleviate some symptoms that usually metastatic disease that is caused, and the most common symptoms that I've listed are pain, for example, bony metastases like a rib met causing pain, some pleuritic pain, but also in the radical setting, of course, for patients who've got the most significant neurological pain that a patient with lung cancer, in my experience, can have is, of course, the pain from a pancreas tumour, which causes significant neurological pain. And that pain, that patients who've got pancreas tumour but don't have metastatic disease, we can treat them radically with a high dose of radiotherapy, not only to cure their cancer, but also to alleviate their pain. So that's a double benefit of radiotherapy for that group of patients. We know that radiotherapy is very useful at alleviating hemoptysis. We're not sure how the physiological how that actually works, but it is very, very effective, and it's very impressive when you see that happen. We also use it, of course, to palliate breathlessness, cough, all of our oncological emergencies, most notably SVC obstruction and spinal cord compression, we can palliate successfully with some radiotherapy. And of course, the other major group that we do a lot of work with is patients who've got cerebral metastasis from lung cancer will benefit from some radiotherapy. And I'll talk a little bit more about that in a few minutes. So one of the things I thought would be useful, and I'm not a technician, I will defer to my wonderful mentor and colleague, Professor David Ball, who will talk much more about the newer techniques in SABR in the next session. But we talk about SABR, image-guided radiotherapy, image-modulated radiotherapy, predominantly in the radical or curative setting. But of course, there is also a role for having SABR for patients who've got oligometastases, or indeed some metastases as well. It is also important, I think, and a challenge for all of us to work out with the newer agents, particularly with the targeted therapies and immunotherapies, what way we need to sequence our treatments. In our multidisciplinary clinics, we do talk a lot about when we should suspend the targeted therapies before embarking on a course of palliative radiotherapy, when we should recommence them. And I think that's an area that we could certainly do some more research to get, rather than second guessing that we know what we're dealing with. Brain metastases, as interesting coming in here today and coming up, we talk about the advances we've made in lung cancer, and we've made many. But I would challenge us all, oncologists and nurses in allied health, the area that we need to do most work out, it would suggest, is in brain metastases. And in some of our newer radiotherapy techniques, we are using, our colleagues are using successfully some of the hippocampal sparing techniques, and that's important because it preserves memory for patients who have got cerebral metastases. And also for where patients are living longer with these new drugs, that is very important, because we don't want patients to have the detrimental effects of radiotherapy as they're living longer. So dilemmas for tomorrow, we've got many, even though we've solved many so far. And I think the combination of treatments, combining some of the newer agents, the immunotherapies and targeted therapies with radiotherapy in the radical setting, but also in the palliative setting. The sequencing of treatments, we need not to trip each other up. We need to know which way is the right way to offer these patients treatment. And I put in the abscopal effect, and some of our colleagues have published on this, notably Shankar Siva, who's a radiation oncologist who we work with, about the abscopal effect of radiotherapy. In other words, if you give radiotherapy to a targeted tumour, it can also activate the immune system. And working that with some of the new immunotherapies is quite exciting for the future, but we need to be cautious about it. So implications for us as nurses, and we can't, of course, talk about the implications for us as nurses without partnering with our patients. I think radiotherapy is very much person-centred. Everybody's radiotherapy plan of treatment is unique for that patient. It's the most person-centred, individualised type of treatment that we offer our patients. We talk a lot about trying to manage those patients' expectations. When we talk to patients and get excited about our good results in both the curative and in palliative, their expectations may be different than ours. And my colleague Paula Nelson and I talk about this almost weekly. We need to think about how we manage patients' expectations for the results of treatment, their families' expectations, and if we're honest, our own expectations. We work in an area that's challenging, but very, very rewarding. And I think it's okay for us to be disappointed if we don't always achieve what we hope to achieve. Self-care, we talk about self-care for patients. I think we need to talk about self-care for ourselves, and I would encourage you all, if you're here on Wednesday, my colleague Maria Fitano is going to give us a succinct reminder about the importance of looking after ourselves. And again, the research opportunities to partner with not only our medical colleagues, but with our allied health and our radiotherapy technicians and our patients in how we can improve patients' outcomes from lung cancer with radiotherapy and other regimes. Take-home message, there's definitely a role for radiotherapy in lung cancer. And there's a role for us as nurses in education, information, and in clinical care. And in acting as interpreters, we talk about that, explaining what we mean about the newer techniques and why they can't be used as much as why they can be used. Thank you.